Hi, I'm Michael Howell. I'm Google's Chief Health Officer, and I'm sorry that I'm not there in person this year. This was one of my favorite conferences of all of 2025, and I had a family obligation this year that prevented my traveling. And so I am jealous of Dr. Clardy and Chandu and Yossi and others who are there on our behalf, and I'm sure that you're all having a great time. But the conference organizers have very generously offered to let me give a few recorded remarks. And so I thought what I would do is just pick up our conversation from last year, where last year we talked about the history of AI in health. We talked about this three-part framework about the three epochs of AI in healthcare. And this year, just a year later, I want to ask the question of, are we beginning to enter even a fourth epoch of AI? And you'll remember last year, where we left off when I was there this time last year, we talked about the first 75 years of AI. We went all the way back to Turing in 1950 and walked through how the deep learning era was different than the era of foundation models and generative AI. And today, I'm not confident that we're in a fourth epoch, but I am beginning to see pivot points that I think matter. And I wanted to tell you a little bit about each of these. And so the first question is this idea of models that move from knowing to agents that do. And healthcare is not just a knowledge problem. Healthcare is a problem about action. Knowing that you have a diagnosis without treating or taking action can be harmful, not helpful. And so we're beginning to see this shift from chatbots and knowledge retrieval and summarization to things that can act, that can identify the need for testing, can help patients find testing, can help doctors take actions without having to be directly acted upon. We're early in that era, but we're really beginning to see some of the value there of moving from knowledge to action. And that's one of the foundational principles of clinical medicine. Clinical medicine is not just about education or knowledge, it is about action. That's pivot number one. Pivot number two is that we're starting to see these new interaction patterns that are emerging. It's not just that there's one agent doing something, it's that you can have teams of agents. And so here I've mocked out a lab, right? You have agents that are good at hypotheses about mitochondria, transcription, and you have tools that are good at doing reviews. And then if you've ever run a lab, like I have, you need to do budgeting and estimate ROI, and you have a list of investments you can make. But I've always been fortunate enough to have a really grumpy senior researcher who's like, it's a terrible idea. But if that researcher ever says, that's a good idea, you know it's a good idea. And so we're beginning to see partners build these teams in the way that healthcare is a team. And so one way to think about AI is a new teammate that's joining the team. And we're beginning to see ethicists who are writing about this. This is a program at the Radcliffe Institute at Harvard, writing about the evolution to the doctor-patient AI triad. And I think we're gonna see amazing science and amazing experimentation in this pivot. The third pivot, which has been one of the most amazing to watch unfold over the past single-digit months, has been the emergence of tools that can help everyone build software for themselves. We see this with AI Studio from Google or with anti-gravity, and we see it with other tooling as well, that it is now true that almost anyone can create software that can do anything. That was not true when we were together a year ago. And if you haven't, with your own hands, played with these tools, with AI Studio or with anti-gravity, this is probably the best way to change your mindset from the chatbot era, the AI 3.0 era, to the era that we're in now. We're seeing the emergence of ephemeral software, not built only by engineers, but maybe built by everyone. The fourth pivot that we're beginning to see is this idea of time and space as truly first-class variables. Now, You have to know a little bit about how these models are trained, right? At their core, they start off as language models. Take a big set of documents, throw them in an embedding space, move all the tokens around until they make sense, and you encode a lot of knowledge that way. And that's amazing for multiple choice tests and reasoning through diagnoses. But in my heart, I'm an epidemiologist. And epidemiology is built on time and space. And so our teams have been working very hard on how to encode time and space as first-class variables, not as afterthoughts. Language is a very lossy compression mechanism for the idea of time and space. We're seeing these amazing advances here, from predicting cholera outbreaks to understanding population health for non-communicable diseases to understanding other things where time and space are first-class variables. And that's at global scale, at planetary scale. Our product for this is called Earth AI. We also have something you can build on top of called the Population Dynamics Foundation Model. But it is also true that time and space are very important at the molecular level. We see that with protein folding, we see that with molecule interactions. And so the fourth pivot that we're seeing is about time and space being built into the models at the foundational level, not appended as an afterthought. And that is very important both for molecular discovery, but also for epidemiology and population health. And that's new since we were together last. And the fifth pivot that we're starting to see is this digital physical bridge. And that's coming in two ways. We're starting to see the emergence of people wearing glasses with cameras on them, which changes the kind of input that these models get, moving from a static camera view to an egocentric mobile view like people have. And I think that we should expect that that will change how the models learn and what they're able to learn. But the second area is that we've seen these amazing advances in general purpose robotic controls. And that as we all know, much of healthcare will always be physical. That's true in the operating room, but it's true in home care. It's true in physical therapy. It's true in occupational therapy. And so these advances that, we're still in early days in, but these advances are likely to be very important for overall healthcare. And so when you add up all of those pivots that we're seeing, even really since we were together just 1 year ago, it's a startling rate of progress. And what it brings to mind is this idea that we need to not just think about the technology, but we need to think about the work and how we do the work. And so healthcare, for my entire career, since I started training in the last millennium, healthcare has been about cognitive scarcity. How many doctors do we have? How many nurses do we have? How can we best deploy them? How can we deploy pharmacists? Where can our research scientists be? And so cognitive scarcity has been a foundational design constraint of nearly everything we've ever done. We're not there yet, but you can start to see these signs that what the hard question that could be emerging is this idea of moving from cognitive scarcity as a design constraint to cognitive abundance as a design principle. I don't know what that's going to be like, but I really want to work there. And so I am even more optimistic than this time last year, and I'm only sad that I'm not there with you in person. I hope you're all having a great time. Thank you.